Now, according to the World Health Organization, hypertension causes death of up to 7.5 million people every year, and hypertension is another name for high blood pressure. Now, the Hypertension Day is celebrated every 17th of May every year, and this year's theme was Count Your Numbers. And this is just to make awareness on what hypertension is, what are some of the complications, and how it can be treated. Our topic of discussion today is hypertension. We have Professor Elijah Ogolla who will be helping us with the discussion just to see what are some of the risk factors and whether there is a relationship between hypertension and some of the heart diseases there are. I welcome you to the show. Be part of the show. Ask us a few questions. Call us live. The number will be displayed at the bottom of your screen, or use the hashtag #MyDoctor to talk to us on Twitter at EbruTV Kenya and at Purity_Museo. You're watching My Doctor Show with me, Purity Museo, and I'll ask you to sit back, relax, and learn from the exciting show ahead. Professor Elijah Ogolla is a cardiologist who will be helping us with a discussion on hypertension. Feel free to talk to us on Twitter at EbruTV Kenya and at Purity_Museo. Use the hashtag #MyDoctor. You can also drop your comment or question on our Facebook page, which is EbruTV Kenya and Purity Museo. Now help me welcome our special guest for the show today, Professor Elijah Ogolla. Thank you so much for making time for us. Welcome to My Doctor Show.
Yeah, thank you for having me on the show.
All right, and let's begin with the simple, with the basics, rather, defining what hypertension is. When we talk about hypertension, what are we talking about, Prof?
So hypertension is the name for high blood pressure. And basically, it's just that we have the heart and the circulation. The heart pumps blood so that it takes, oxygen, new food, and all those things to our various organs. Our brain, our kidneys, our muscles, our stomach. And it does this through a series of pipes, which are the blood vessels, the arteries and the veins. Like any liquid flowing in a pipe, you need a certain amount of pressure for it to flow. As you know, if you have low pressure in your water system, then maybe it doesn't get to the first floor, something like that. So we need a certain amount of pressure for the circulation to be adequate, for the blood to get where it needs to get to. But if it is too high, then that's not good for us. And that is what is called high blood pressure. And it is not good for us because it causes certain complications. So it's not just the numbers, it's not the pressure per se, it's the complications that arise out of a blood pressure which is not controlled.
Yeah.
And maybe just to explain, because many of you will have been told your blood pressure is this over that, and maybe that can cause confusion. Of course, the circulation of the blood is dependent on the heart pumping, and the heart pumps and relaxes. So when the heart pumps, there's a surge of pressure, so that's the upper figure. And when it relaxes before it pumps again, the pressure falls down. So the first one, the upper figure, is called systolic, those who are interested in the technical name, and the lower one is called the diastolic pressure. Yes.
So what exactly happens? You said it's all about the heart pumping, and now what causes high blood pressure, this condition?
We broadly classify high blood pressure or hypertension into two types. There is what is called essential hypertension, which is a rather unfortunate term because there's nothing essential about it. It's sort of historical. It was believed several years ago that as you grew older, your blood pressure needed to rise. And you could call it primary hypertension. That means hypertension without a specific defined cause. Although, as I'll mention, there are actually defined risk factors for it. Then there's what we call secondary hypertension. So secondary hypertension is hypertension due to a specific problem that if got early and treated, then you essentially cure the hypertension. And maybe because it is the smaller one, I can dispense with it quickly. The commonest causes of secondary hypertension is usually kidney disease. So most people with kidney disease have accompanying hypertension. So part of their treatment is treating the hypertension. There are several drugs that can cause high blood pressure. You can have high blood pressure related to pregnancy. You can have abnormalities of the blood vessels that lead to high blood pressure. And there are several hormonal problems that can lead to high blood pressure. So this is what we call secondary hypertension. But secondary hypertension is actually the minority. So that in adult populations, it probably will form about 5 to 10% of hypertension.
Is it because it's linked to what you're saying, the kidney disease?
Yes.
All right.
So the big problem that, you know, from a public health point of view, we have to confront is this large animal called essential hypertension. Now, what causes essential hypertension, which is sort of like a contradiction in terms because we have said it has got no cause.
Yeah.
But they are defined things that increase your risk. So we often call them risk factors rather than causes.
Yeah.
So what are some of the risk factors? Obviously, there's a genetic component. So there are families in which, you know, hypertension is common. So if you have a first-degree relative, a father, you know, a sibling, a mother who has got hypertension, your chances are higher. But then there are environmental issues that we can deal with, and they are important from the point of view of, one, preventing hypertension, because we can prevent, and also as part of the treatment. So the common things is alcohol intake. So excessive alcohol intake causes high blood pressure. Second thing is salt intake. So excessive salt intake contributes to high blood pressure.
And when you talk about excessive, Prof, what exactly do you mean? Because there are people I know that really take so much salt, but when you say so much, because my salt intake may be different from yours, and also alcohol as well, what are quantity?
Okay, fine. Let's start with the alcohol because it is even easier to define. Generally, we talk about a unit of alcohol. Of course, when you go to a bar, you don't ask for a unit of alcohol. But a unit of alcohol basically is like a glass of wine, a tot of a spirit, or a 300 ml bottle of beer. So that's what is called a unit of alcohol. So the recommendation, and this is not just about high blood pressure because alcohol has got multiple, you know, health effects, is that for men it should not be more than 2 units per day, and not every day of the week. And for the women, because women metabolize alcohol differently, so for any given quantity of alcohol, they tend to get higher blood levels. So the recommendation is 1 unit per day, and again, not every day of the week. And a particularly dangerous from a health point of view form of drinking is what we call binge drinking. So those who, you know, keep dry the whole week and then, you know, on 1 or 2 days, usually over the weekend, then they drink excessive amounts. So that's about alcohol. About salt, we say that you should have no more than 5 grams of salt per day. Now, of course, nobody puts their salt on a weighing machine. So that's about, you know, it's about a tablespoonful of salt for the whole day. Now, the other thing we should know about salt is that there's the discretionary salt, the one you as Purity decide to put or not to put, whether it is at cooking or on the table. But as we urbanize and eat more and more processed foods, a lot of our salt consumption actually is from the processed foods. So things like soups contain a lot of salt, bread contains a lot of salt, processed meats, you know, like sausages or whatever, all those things contain a lot of salt. So one has got to take into consideration all those things when you're talking about. So if you've eaten 2 sausages and you drank a bowl of processed soup and 3 slices of bread, and you say, but today I've not added any salt, you've actually still consumed a lot of salt. Of salt,
all right.
So we were going on with the causes. So I mentioned alcohol, I mentioned salt. Weight. There's a clear association between obesity and hypertension. And it's usually a conglomeration of things that tend to occur together: obesity, diabetes, hypertension, they tend to occur together. Now, one thing that, which is a sort of new emerging concept, one thing that obesity causes that then independently worsens the hypertension is that many obese people have difficulty sleeping at night. So there's a concept called disturbed sleep breathing or obstructive sleep apnea. If you Google OSA, you'll get it.
Right.
So these people tend to have difficulty in sleeping, in breathing when they are asleep, because the muscles of the throat sort of relax and collapse, so they have to, sort of wake up so that they can breathe again. So that itself is a major risk factor for high blood pressure. Lack of physical activity is another source of, cause for blood pressure. Smoking is another cause for blood pressure. So there are this, although we say it is primary hypertension, there are these various risk factors that if we deal with, then you can control your blood pressure, which means, in essence, you can actually prevent hypertension.
Yeah, and Prof, allow me to take you back. When you talk about hypertension, what's now at this particular point is abnormal? Okay.
Yeah, it's been a moving target. Since I've been around for a long time, I've seen it move quite a bit. But there are two concepts. You can define blood pressure at the level of blood pressure at which you begin to see harm. And incidentally, that is pretty low. That is pretty low. So we more conventionally define blood pressure at that level of blood pressure that it has been shown that if you intervene, you treat it, then there is benefit. So conventionally right now, it is less than 140. This is measured in millimeters of mercury for the upper figure, and less than 90 for the upper figure. Now, since we live in the information era, maybe somebody is going to ask me this, because the Americans upgraded what we call guidelines late last year. And they actually reduced that to less than 130 and less than 80. We in the continent, because I'm sort of involved both with the African guidelines and with the Kenyan guidelines, we in the continent think that is probably artificial. We'll get to some statistics later about how much hypertension we have, I hope.
Yes.
And I'll show you that even at that 140 over 90, we're very, very far from achieving our targets. So we don't think we need to change. And the other big body that produces guidelines that many people in the world use are the Europeans. It's the European Society of Hypertension. They have updated their guidelines. It's still sort of embargoed because they are going to launch it in their next big conference in about 3 weeks' time. But we know for sure that they have also stuck to 140, 90, so they have disagreed with their colleagues across the Atlantic.
All right.
So I think for now, for simplicity, it is
140 and 90.
Yes.
All right. And now let's not leave that discussion on the prevalence of hypertension in the country. Maybe you could tell us the numbers.
So the numbers we have is that if you look at the entire adult population, we have a prevalence of about a quarter. We almost 25%, about 24%. But that is taking everybody from 18 up to this. It's a big survey we did with the Ministry of Health, which is just about to be published. But now if you disaggregate that and look at age segments, then you realize that it increases very sharply with age. So that by the time you reach the 40s, the prevalence is actually in the 40%. And by the time you reach the 50s, especially above 55, then it's actually more than 50%. So more than 1 in 2 people, adults over 50 years of age, and obviously we have an aging population, has got high blood pressure.
Yeah.
So that is very scary. Now, since we are on the statistics, a little more of the statistics, Of this number who have high blood pressure, if we look at the national figure, just about 15% know that they have high blood pressure. So out of every 10 people with high blood pressure, less than 2 are aware that they have high blood pressure.
Is it because of lack of awareness, or why is it so?
It is lack of awareness, and we're going to talk about some of the mechanisms we can do, worsened by the fact that high blood pressure itself is a symptomless disease. So unless somebody takes an initiative to have his or hers measured, or somebody takes an initiative to measure yours, you'll never know you have it until you have a complication. So there's that low awareness. Now, of those about 15% who are aware, only about half of them are actually on treatment. So that figure drops to less than 8%.
And now, Prof, how do you explain you are aware you have high blood pressure and at the same time you are not under treatment?
The explanations are multiple. A lot of it is failure with the healthcare system. Maybe we don't tell people appropriately the fact that this is a chronic condition that you have to be treated for forever. Many of those not on treatment are people who are probably actually started on treatment, given a 1 month's prescription, and were never told that you have to continue treatment. Part of the problem, and this cuts across many illnesses, is inherent weaknesses of human behavior. Adherence to drugs is a big problem. If you take a vote, even the antibiotic that is given to you for only 5 days, and it is 3 times a day for 5 days, so that's 15 doses. You ask how many people actually take those 15 doses as prescribed. It's actually, you'd be surprised. Now here, consider a condition where you have to take medicines for life. So you probably started at 40, which means you have to take medicines every day for 40 years. And it is a disease that does not cause you any symptoms. And maybe the drugs actually may make you feel worse because drugs have their side effects. So these are the issues that we as the healthcare system have to work with patients to motivate them, to reinforce the message, to appreciate that fact that you're doing this sacrifice, as it were, to prevent a catastrophe. So final thing, maybe final 2 things on the statistics. Now, so we said by the time we get to how many people are on treatment, we are less than 10%, about 8% or so. The unfortunate thing is that even those on treatment, only about half are controlled. So if you look at the Kenyans with high blood pressure, it's just about 5% that are controlled, which means that of every 20 Kenyans with high blood pressure, only 1 is controlled. So we have a lot of work to do, because obviously the reason for knowing is so that you can get treatment, and the reason for getting treatment is so that you can get controlled. Yeah.
And failure to control the other percentage, is it because of the gap, a treatment gap that we have as a country, or what is the explanation?
Again, largely some of the things I've already said.
Yeah.
And also part of the problem is that obviously a large proportion of our population seek health care from the public sector. And unfortunately, the non-communicable diseases have sort of not gotten the attention that the communicable diseases have got. So that, for example, if you go to the lower levels of the public health system, you might not get drugs for hypertension. There may be stock outs, and these are wananchi who are probably not able to access private health care or buy drugs on their own. And then, of course, the other issues I talked about, it's a chronic illness, you're not feeling anything, so you don't feel motivated, one, to go for your follow-ups, which probably takes a whole day every month out of your very busy schedule trying to make a living for yourself and your family. So there are all those multiple factors. Part of the poor awareness, I didn't mention it. In this survey, we asked people if they had ever had their blood pressure measured at all. And about 60% have never had their blood pressure measured at all. So again, I think that's a failing on us as the healthcare system, because we have to create the opportunity for people to have their blood pressure measured.
Right. And now, Prof, I don't know whether I should be asking you the symptoms for hypertension, because you said it's a symptomless disease. Do we have some signs for hypertension?
The bottom line is hypertension per se, no symptoms.
Right.
So people tend to falsely associate hypertension with certain things, headache and all that. And sometimes actually that causes a problem in adherence. The high blood pressure was discovered because I had a headache, and because the headache is gone, it must be cured. So essentially, hypertension is a symptomless disease. Of course, there are exceptions. If you have very severe levels of blood pressure, you'll have acute symptoms. You might have blurring of your vision, you might have headaches, you might have pounding of your heart and all that. And once it causes complications, of course you'll have the symptoms of those complications. And then at the other end, you remember I talked about secondary hypertension. Specific causes of secondary hypertension will have symptoms of that. So if your cause of secondary hypertension is kidney disease, of course you'll have the symptoms of kidney disease. But by and large, this large chunk of essential hypertension, no symptoms. So the only way to know whether you are hypertensive or not is to have that machine put on your arm and measured. So I think that's an extremely, extremely important public health message. Yeah.
All right. And Prof, each time we go to the hospital, most of the facilities will tend to have your blood pressure checked. But then when, for example, you are sick, sometimes the doctor will tell you that the blood pressure is high, the blood pressure is low. Maybe you can also demystify for us whether there is the issue that you talked about, the headache, but when your temperatures are really high, maybe because you are sick, you have fever, is there any relationship with hypertension or high blood pressure?
Yeah, I mean, in terms of the message to get people aware about their blood pressure status, we want you to have your blood pressure measured at any opportunity. Now, in terms of making a decision that you are actually hypertensive, then now there are certain specific steps, because as bad as it is not to treat, it's also bad not to over-treat. So hypertension, or rather blood pressure, is not a constant, it's a variable thing. So if you are stressed because I was caught in traffic and you are and your time is running out, if I measured your blood pressure at that time, it will obviously be higher than your usual blood pressure. So yes, when you go to hospital for any illness, we want, and unfortunately, especially at the lower levels, it is not happening often enough. You must have your blood pressure checked, whether you went because you have a headache or a backache or fever or what have you. But we recognize that the blood pressure at that time might be altered upwards or downwards, for example, by the illness. But the idea is to see where you are, so that then the mechanisms can be set in place if it is elevated, to confirm that indeed it is elevated even at normal state, if you like. Yes, so there's that.
Okay.
But it is still very important, because this is what we call opportunistic screening. Instead of necessarily having to mobilize resources to go out there in the village and come to your home, all of us have an opportunity. Well, I don't think you call it an opportunity, but all of us have an illness once in a while, and you get into contact with the healthcare system. So if we used each of those contacts to measure the blood pressure, then practically everybody in the population would know their level of blood pressure.
Okay, and we take a break now, but when we come back, we look at treatment options for high blood pressure or hypertension. It's another name for high blood pressure. We take a breather, but do not go anywhere. We are coming back shortly with more, especially how do we prevent ourselves from getting high blood pressure. Stay with us. Welcome back to the second and the last part of the show. We are talking about hypertension, which is another name for high blood pressure. We have talked about what hypertension is and what are some of the symptoms. The doctor said, Professor Ogola said there are no symptoms for hypertension, but now we want to have a look at some of the complications that come with this condition. Keep talking to us. Use the hashtag #MyDoctor to talk to us on Twitter at EbruTV Kenya and at Purity_Musia. And now help me welcome our special guest once again. Prof, welcome to the second part of the show. Thank you for staying with us. Now, earlier on, Prof, you said that hypertension is a symptomless condition. But now, what are some of the complications? If, for example, you don't go for checkup and you have hypertension that is untreated, what are some of the complications that we look out for?
Thank you. So, yes, just to stress the fact that the reason we treat hypertension is to prevent the complications. Because like we've said, it might not make you feel anything. And actually, if you remember what I said earlier, we actually use the benefit of preventing complications as the threshold for defining whether your blood pressure is normal or abnormal, which means whether you have hypertension or not. So most of the complications, of course, are related to the heart and the circulation. So hypertension is a major cause of what we call a heart attack. Hypertension is a major cause of what we call heart failure. We don't have time to go on to get into the definition of what is the difference between a heart attack and a heart failure. And in fact, in Africa, we've done studies, and almost 50%, about 45% of all causes of heart failure are attributable to hypertension. Then hypertension is a major cause of stroke. Hypertension is also a cause of kidney disease, and it can also affect the eyes. So the main things is the heart attacks, stroke, kidney disease, and heart failure. And actually, if you look at deaths from cardiovascular causes in the world, hypertension is responsible for more than 40% of them. Yeah. So those are the reasons why we treat your blood pressure, to prevent those things. The
cardiovascular diseases. And Prof, I know you said we really do not have time to get into the details of what really heart attack, what stroke and all that is. But when you have all these complications, what does it mean to a patient of hypertension?
Now, all these things are, serious, what we call in technical term morbidities, serious illnesses, and really catastrophic from a personal point of view, from a professional point of view. For example, if I use the example of a stroke typically presents with weakness of one side of your body. So imagine you're right-handed and you get a stroke on your right-hand side. Probably will affect your profession. You can't even sign your bank checks. You can't drive. You can't do what? Apart from the fact that what we are talking about is the person who survives that event. But when we're talking about strokes and heart attacks, the first stroke might be your last breath because it can kill instantly. The first heart attack might be your last breath, and it can kill. Now, if you survive it, there is the quality of life aspect which I've talked to. You can't continue with your profession. You have to be taken care of, and all those things. And then there is also the economic bit to the person and the family. You probably heard a lot about this terminology, catastrophic health expenditure.
Yeah.
And these non-communicable diseases, especially cardiovascular diseases, are a major cause of catastrophic health expenditure. I mean, they literally dip households into poverty. And it's because there are chronic problems once they occur. So there's the whole issue of dealing with the incident, the stroke, the heart attack, and what have you. But then you also have to deal with the consequences. in the long term. Part of that is loss of earning, but part of that is the continued treatment. So like our ancestors said a long time ago, prevention is the best cure.
Yeah.
Because once it occurs, we do our best, but really the horse has bolted.
And now, Prof, for the complications that come with hypertension, someone may ask, I may also be asking, after how long do you expect to begin seeing these complications? Because sometimes you do not know whether you have hypertension, but after how long, battling with hypertension, do you expect now to see some of these complications?
Well, first, make sure you know your level of blood pressure. So no excuse that I don't know. As to how long, I mean, it's difficult to put a precise time limit on it, but you can have immediate complications in people who have got very high levels of blood pressure. But fortunately, this is a minority. So the majority of people with high blood pressure are people in the sort of mid-range. Now, that being mid-range does not make you safe. It just means that the complications develop more insidiously. So they are not immediate, but they develop over time, over the next 5 years or so, if untreated. And that's why we treat. And that's part of the difficulty on treatment. I mean, as human beings, we prioritize our lives, isn't it? So to convince me to prioritize to prevent some hypothetical thing that is going to happen in 5 years' time.
Yeah.
So that's why we have to do a better job to convince our public that it is worthwhile.
Yeah. So what is the diagnosis for hypertension?
The diagnosis? Well, hypertension is simply those figures.
Those figures.
I measure your blood pressure. It's beyond a certain level. I'm confident that I measured it right, did it in the right circumstances, confirmed it. So it is not high because, you've just run up the stairs or the bank has just sent you a letter to auction your property or whatever you. I confirm that it is. Then that is all it is. So hypertension is defined. There's no other definition. It's purely defined by your blood pressure being beyond a certain level.
Yeah. Now let's get to the treatment options for hypertension.
Fine. So the treatment options, we sort of divide them into non-pharmacological, which is basically lifestyle issues, which actually are the same things that if we did well right from childhood, we can actually prevent hypertension, so we call that primary prevention of hypertension.
Right.
And we also use the same things in treatment. So reduction of alcohol intake, reduction of salt intake, regular physical activity, taking care of your weight, stress issues and all that. So that's part of the non-pharmacological treatment, the lifestyle issues. Now, unfortunately, still, if you already have established hypertension, most people will still require drug treatment or pharmacological treatment on top of that. And we have a variety of drugs that can be used. And I don't think, it's for me to get into the details of the drug classes. There are ways that, your healthcare provider will decide that this drug is better for you, it's better for purity, and this one is better for Ogola, depending on several things. And the other thing is that most often, most people will require more than one drug. And fortunately, these days, we have many of those drugs fixed, combined in a single tablet. So we call them fixed dose combinations. So that helps, so that you don't have this one you take with tea, this one you take without tea, and all that. It makes an already difficult situation much more difficult. So, and again, most drug formulations these days are long-acting, so it makes it easy for the patient. So you just take your pill once a day.
All right.
But it is drug treatment with the lifestyle issues, and by and large, once hypertensive, always hypertensive. So it's something which is difficult because in itself, paradoxically, it can be a demotivating factor when you encounter a new patient. But I think all of us healthcare providers have to be courageous enough to tell our patients that, by and large, I don't say it is lifelong. I say it is indefinite. We'll see as time goes. Maybe you'll be lucky, and I mean, if you are 120 kilograms and you reduce to 90, and you used to take 5 bottles of beer every day, and you've become a good boy or a good girl, maybe we'll draw the drugs. But it is good to counsel our patients that, by and large, it is lifelong. Yeah.
And will I be right if, Prof, I say that lifestyle is the major cause of hypertension, the kind of lifestyle that we choose?
Yeah, when we're talking essential hypertension, yes.
Okay.
Yes.
And do we see hypertension in children?
Yes, unfortunately. Usually, from a clinical point of view, and this is the sort of that traditional thing that I was taught in medical school, when you see a child with elevated blood pressure, look for secondary hypertension. And that is largely true. So when we see a child with high blood pressure, then we look for those other things I mentioned more proactively than when I see an adult with hypertension. But still, unfortunately, we're seeing even children, especially at teenage level, with what really qualifies to be essential hypertension. And again, it's the lifestyle issues, the obesity, the stress, waking up at 5 a.m. to go to school, and you don't get back home until 10 p.m. and all those things. We actually did a survey in public secondary schools in Nairobi with one of my students a few years ago. And if you used the pediatric definitions of hypertension, you actually get very high levels. But the scary thing was that if we used the adult definition, which is the 140/90 we talked about,
right,
still 7% of these kids had high blood pressure. So it's something which is, and reinforces the message I talked about, the primary prevention. Right. Preventing it from occurring. And that we can only do by focusing on kids.
Yeah. And Prof, when you talk about preventive measures, is it avoiding the risk factors that you highlighted, or do we have more?
It's basically about taking care of the risk factors.
Yeah.
I mean, we can't do anything about our genes, but we can do something about what we do as human beings. So yes, yeah.
But it cannot be cured completely, that's what you said?
No, no. But sort of yes and no. Since we define it by a number,
yes,
if I do the right things and below, and it comes below that number and remains below that number, then yes, essentially, then you could consider it a cure.
Yeah. Let's get now to the gap. When you are highlighting some of the statistics or where we are as a country, you mentioned that some people know of their status, but they cannot access some medical or treatment for their conditions. So where is the gap? Where do you think is the gap in the country right now in helping hypertension patients?
So the gap really is at various levels. If you look at the statistics again, the biggest gap is the awareness gap. Because once they are aware, at least about 50% are treated. Of those treated, about 50% are controlled. Not good enough, but better. So the biggest gap is the awareness gap. So creating awareness. And there are multiple things. One of them, you mentioned the World Hypertension Day. So what has happened actually over the last 2 years is there's a global organization called the International Society of Hypertension. So because the World Hypertension Day falls in May, like you said, 17th May, so for the last 2 years, we've made the whole month of May a hypertension awareness month. So we call it May Measurement Month. And so we go out there and screen and screen and screen. So like this year, we haven't collected all the statistics, but it looks like we reached about 35,000 people. So these are new people who were not aware of their blood pressure status before. These are not just hypertensive, it's all people we screened. So there are those awareness things. There are other initiatives. There is an initiative that I'm involved with called Healthy Heart Africa that is working with various partners, AMREF, these big NGOs in the health sector. We've been doing this since about 2015, I believe, and we've screened about more than 6 million Kenyans. The Ministry of Health itself is, increasing its hypertension activity so that screening for blood pressure once you get to a health facility for whatever reason is more systematic and all that. So that's the awareness bit. Then of course there's the treatment bit. So this is both now the health system and the patient. So many of our, if you like, lower cadre healthcare workers, who are the people who see the majority of Kenyans? The clinical officers, the nurses working in the dispensaries. The sensitivity to non-communicable diseases has not been very good. So these guys are very good, for example, in treating HIV, TB, and all that. They'll tell you what is second-line drugs and all that. But they haven't been empowered to treat non-communicable diseases, hypertension being one of them. You will be surprised that in many facilities you might not have a functional blood pressure machine or a glucometer to just measure sugar or a weighing machine to check people's weight. So these are some of the activities that are being upscaled and making sure that blood pressure medicines now get in the Kenya healthcare system, I think up to what is called level 2, which is the health center level, not quite the dispensary level. Although if you asked me, I don't see why they shouldn't be at there. We have some very simple drugs that can be prescribed, in my opinion, even by nurses. All they need is training and give them proper referral mechanisms so that when they get stuck, they know. So that's now the treatment. So you become aware, you start treatment. The next gap then is the control gap.
Right.
Which again is both their patient factors, their system factors. So make sure that the drugs are always there, because that is not the case in our public health institutions all the time. That people are motivated to come back for their blood pressure checks. That there's something called physician inertia. Purity comes to me and the blood pressure is 150/97. I know this is good control. And I say, do I want to increase the medicine? Let's give it another 3 months, okay? So to make sure that we are more proactive in achieving targets, talking to our patients, reassuring them about side effects and all those things, reinforcing the message about lifestyle issues. There's no problem. There's no point wasting your money buying expensive drugs, and you still go and drink 6 bottles of beer every day. Okay? So all those things. So we have to take care of awareness. We have to take care of initiating and maintaining treatment. And we have to make sure that those on treatment actually achieve target.
Now let's talk about the guidelines that are there as at now for, I know it's difficult to say for hypertension, but for cardiovascular diseases, when you relate them to the gap that you have you have talked about, where do you think we are on the right direction as a nation, or do you think there need to be adjustment of the guidelines that we have right now?
Now, guidelines are good, and I participated in the development of the Kenyan guidelines. In fact, I'm the lead author for the hypertension bit. But the problem with guidelines is they only take care of that bit once the guy is in the clinical context.
All right.
So that is important, but the guidelines per se don't usually address this, if you like, upstream factors. So yes, guidelines are important because it helps the clinical practitioner know what to give for what are the expected side effects, what can you combine with what should your patient avoid. So it is important. So because of the fact that guidelines need to be sort of restricted in their reach, at a continental level, we have an organization called the Pan-African Society of Cardiology. I happen to be the Secretary General. So we have actually produced a guideline, but we call it a roadmap.
Right.
And the reason we call it a roadmap is now we tackle issues beyond purely what guidelines traditionally do. So we tackle the awareness thing, we tackle the adherence issues, what can be done at a national level, at a county level, and all those things. So yes, I'm very happy that we finally got our national guidelines. And as you probably know, we launched them about 2 or so months ago. And it's not just for high blood pressure, it is for a variety of cardiac conditions. But guidelines will help us only so much. We have to take care of these broader issues.
Yeah. Let's now just help us understand, how do we take care of them? The numbers that you have really said are worrying for a nation. So what ought to be done? You participate in the making of the guidelines, but where are you not doing actually enough to ensure that we reduce the numbers in terms of the people getting access to treatment, controlling, and also making awareness for people to go out and check their blood pressure?
Okay, maybe I will start by saying, by the way, and this is not an excuse, by the way, globally, control rates for hypertension are really poor, and it's really a global issue. Now, that is no reason for us to rest on our laurels. We really have to do better.
Yeah.
And I think the measures are those things that we've talked about. The measures we are doing in terms of raising awareness at a public level, and something like this helps. I don't know what proportion of Kenyans actually watch TV, so maybe it is an elitist thing, but we have to do it at all levels, in barazas, in churches, in workplaces, in schools. I'm told the penetration of mobile telephony is highest in Africa. It's probably the only thing where we lead the world. I mean, we can use it more creatively to do this, and make sure that our health care system is working. Because that's really the bottom line. Because when you are running an institution, I'll come here and talk about hypertension. Somebody else will come and talk about complications of pregnancy. Somebody else will come and talk about childhood illnesses and cancer. So ultimately, it is a working healthcare system that takes care of all these things. And I'm hoping that our UHC will probably help us tackle that. Yeah.
And Prof, allow me to ask you this question. I know you've mentioned earlier on, but it's important to making awareness on hypertension. But now, for someone watching, they don't know what they did not know what hypertension really was, but now they know. Just emphasize on why it's important for just go out and check your high blood pressure. Maybe let's try make some awareness.
So maybe I'll put it in maybe a few sentences. One is that hypertension is very common. So if you don't know about it, chances are you probably have it.
And it can affect both male, female, children,
female,
and adults.
Poor, what have you. And if you are out there and you are more than 50 years, then your chances of having it is more than 1 in 2, more than half. So check it. 2, hypertension does not make you feel anything. So unless you take that initiative and check it, you'll never know whether you have it. 3, if you live with it, whether you know or don't know, but you live with it without treatment, chances are you're going to have a catastrophic complication. And 4 is that there's something we can do about it. If we discover it and treat it, we're pretty successful in preventing these catastrophic complications.
Right. And let's shift our attention to monitoring your blood pressure. How regularly should you be checking your blood pressure?
Well, it depends on, usually if you're newly diagnosed hypertension or hypertensive, and it also depends on how high it is, you probably would want you to be reviewed at about a month or so. But for somebody who is on long-term treatment and the control has been good, you can be seen every 4 to 6 months, really, so that it doesn't unduly disrupt your life and also clog the healthcare system. Now that you brought the question of monitoring, it brings another concept which I was not even thinking about. But the fact that these days we can monitor our blood pressure from home. So we have these digital machines. Technology has improved, so there are some of them that are very good, but please check with your healthcare provider so that you are advised. One on what we call the validated machines, so the ones that have been checked by the experts, because of course the vendors want to sell, so they'll give you everything. And also 2, on how to accurately measure your blood pressure. But that is very important in two respects. One, if you have your own, it means you can measure it as many times as possible. Two, since blood pressure varies, the pattern of a multiplicity of readings gives us more information than one reading on the one day in 4 months that you come to see me.
Right.
And three, we've actually found out that the measurements taken at home give a better idea of your likelihood of complications than measurements taken in the clinic. So I think, and these machines are, well, relatively cheap, especially for the middle class.
Yeah.
You can get a good machine for less than 10,000 shillings. And it is something that has got no input at all other than buying a battery from time to time. So it is something which is useful.
Yeah.
Yeah.
All right. And Prof, when we once again go to the hospital and out of an illness, your pressure is a little bit high, or especially for pregnant women, how do you control that blood pressure to just, the pressure rather, to just ensure that it's not going to be a problem like hypertension, it's just a varying blood pressure like you had said?
Yeah, well, hypertension in pregnancy is actually sort of a very specific area. And because the developing baby tolerates high blood pressure very poorly, so that our thresholds for treatment are actually sort of much lower. So there is hypertension. These days we use the term hypertension in pregnancy because it could be multiple things. I probably was just hypertensive and, you are now pregnant. Then there's the hypertension that is induced by the pregnancy itself, which typically resolves after the pregnancy. Although we know those people are also at higher risk of having now sustained hypertension. So there are clear guidelines on how they should be treated depending on the blood pressure, from just bed rest alone to specific drugs. And in pregnancy, because of the fear of toxicity to the developing baby, there are only specific drugs we can use.
Yeah.
So that some of the drugs that we use very routinely in the general population, we cannot give to pregnant women.
And Prof, as we wind up, what's your message to hypertension patients? You said that it cannot be cured. So what's your message? What do they need to do? What are some of the do's and don'ts for patients of hypertension?
So if you already have hypertension, in a sense you are privileged, because you're the 15% of the Kenyans who know their blood pressure status. Like I said earlier, by and large, hypertension is not curable. So you need to continue to take your drugs, be in constant communication with whoever your healthcare provider is, whether it's a public institution, whether it's a private facility and all that. Do not forget the lifestyle issues, because they're extremely important. And continue to take your drugs. Continue to take your drugs, unless your healthcare provider advises otherwise.
All right. Thank you so much, Professor Ogolla, for making time for us and for that informative session. We highly appreciate. That's all the time we had for the show.
Thank you very much.
All right, and thank you so much for watching. My name is Purity Museo. Now you know what to do to prevent hypertension, what are some of the precautions and the risk factors. Thank you so much once again for your comments and contributions. I want to leave you with some home remedies for hypertension. Goodbye for now.